So when we're talking about going from the recovery room, your patients that are going to stay in the hospital for a while will go back to a med-surg unit, or they will go to the intensive care unit. It depends on how much intensive monitoring that they need, okay? But the room really should be ready for the patient, and it really needs to be set up so that there's the minimum amount of jostling and moving and aggravating the patient once they get to the room. This is just the standard things that you need, all right? There needs to be your blood pressure and vital sign monitoring equipment needs to be there, ready to go. Because what happened when the patient got to the PACU? What's the first thing that we did? We put them in the bed and we immediately started our assessment, right? That's exactly what you're going to do when the patient gets to your room. Okay, you're going to immediately start assessing the patient. So we need vital signs. Your patient may be nauseated because we have jostled them from this end of the hospital to the other end. Okay, so emesis basin. The bed needs to be set up. It's a clean bed, clean sheets. It needs to be set up so that if you have the patient that may have a lot of drainage or be incontinent, you've got your bed padded. Trust me, this just makes it easier on you too, right? So pads, extra pillows. You may need to have some extra positioning that we don't normally do with our regular medical patients. So, and then depending on the type of surgery, there should be those extra things in there. If you have a patient who has had some type of arterial surgery, there'll be some extra monitoring equipment in there. Your SCD pumps should be in there and ready to go. So those kind of things, just making sure you've got everything that you need. When the patient gets there, they will be accompanied by the PACU nurse. This is going to be a licensed person that's bringing the patient to you. They've called report to say that they're coming, but then when they get there, the nurse on the floor should be in the room to accept the patient and get a face-to-face report on how the patient has done in the PACU setting. Okay, so it's another face-to-face report. The nurse has to be there. If the nurse is not in there to receive the patient, the PACU nurse will stand there until they get there. And that makes them crazy if they have to wait on you. Okay, so be there. Your patient's coming. Be there and be ready to accept them. You are going to help get the patient in the bed. And you got to make sure that you're not pulling out tubes and all that business. You have to be very careful. Reports should tell you what kind of tubes, bless you, should tell you what kind of tubes and dressings and all that business that they have going on, so be careful with that. I've seen Foley's pulled out, and they're not deflated when they're pulled out. IVs pulled out, so just be very careful. Be very careful of your linen, right? So we're going to get vital signs, and we're going to start our assessment. Because they document on their form what time they have turned that patient over to you. And then your documentation should start immediately after that. Okay? When you're doing your initial assessment on the post-op patient, it's really not any different than any other assessment that you do on a patient. It's a head to toe, right? What is your baseline data at this point? They have moved to another standard of care, another level of care. Right? They're no longer in an intensive care unit. I'm really talking that they're on a med-surg unit, medical unit. Okay, so they've moved to another level of care. But we still have to get our baseline. How was the patient when they left, when they got to you? Because we're going to be talking about some changes that you're going to be comparing some data to see, is the patient really having the problems that you think they are, okay? So look at those IVs, look at the site. Don't just take for granted that they said the site is fine. Maybe we pull the IV out as we move the patient over. Look at the drains that they have. What is it draining? What does it look like? What does their dressing look like? So look at everything. And your assessment will change just a little bit based on what kind of surgery that they had. Right? Because I'm going to do a head to toe. Of course, I'm going to listen to the lungs, and I'm going to check the heart and vital signs and all that business. I'm going to check neurostatus. But if somebody has had an orthopedic procedure, I'm going to delve a little deeper into their musculoskeletal and circulatory status at that time. Okay. So just think about what they had and adjust accordingly. But you're still going to do that basic head-to-toe assessment that you know how to do. Okay. So when we talked the other day, we talked about some potential issues that your patient can have after surgery. What are some of the things that I said that every patient who has surgery is at risk for? Pneumonia, infection, injury, what, Jansel? Deep vein thrombosis, shock. Good Lord of mercy. Y'all were listening. Oh my gosh. And it was late too, so that's great. Okay, good. Absolutely. Everybody is at risk for those things. So we're going to spend the next talking about how you're going to assess, look for some of those things, and then what your interventions are when you find them. Okay? So you know the patient coming back to you from OR has these risks. So that's our job, to be diligent and look for them. Look for those complications and ward them off, hopefully, before they happen. So, potential respiratory alterations in the post-operative patient. This is them, right here, okay? Airway compromise. Your goal is to maintain that airway. You've got a sleepy, groggy, lethargic patient, okay? They may not be able to control their airway adequately. Right? So your patient may come to you from PACU still having an oral airway in, which is that device that keeps the tongue pulled up from the back of the throat. Okay? Usually they don't. Usually if they're still needing an oral airway, they're staying in the PACU, but every now and then you may get a patient with an oral airway in. I'm not talking intubated. That's different. You will not see a patient return to you on a med-surg floor intubated. That's not going to happen. But an oral airway may be in. Your patient, of course, we talked about they have risk for hypoxia. They're breathing, but maybe they're not taking those good deep breaths to oxygenate the rest of the body like it needs to. Atelectasis, what in the world is that? Collapsing alveoli, right. Again, no good, real deep breaths. That's why we have to, a lot of times, make sure our patients are awake enough, and we have to stimulate them to take those good breaths, deep breaths. Pneumonia, you know what that is. Pulmonary embolism, we'll talk about in a minute. Laryngeal edema, they've had a tube down their throat through their vocal cords, so they can have some swelling there. Your patient may remain ventilator dependent. They just can't get the patient extubated. They can't get them awake enough to get good breathing, et cetera, so they may have to stay intubated and then be put on a ventilator. That's not going to happen on your med-surg unit either. And then, of course, your patient always has the risk for pulmonary edema because we have them back in surgery and we're putting a lot of fluids into them. Of course, they got fluids coming out of them too, but sometimes that's not quite the same. What goes in may not be what comes out. Okay. So when the patient arrives to you, what position did I tell you in the PACU we put them in? Semi-Fowlers, we're going to do that in the post-op unit as well. Okay, we need to put them semi-Fowlers. This patient is usually on oxygen. Okay, we usually keep folks on oxygen for about 24 to 48 hours after surgery. Again, that's most of the time. And then we're going to start, encouraging those breathing exercises and the turn, cough, and deep breathe that we taught them pre-operatively. Okay. So what do we see when we have respiratory problems? Usually what happens is the body tries to compensate. Okay, so the respiratory rate goes up, trying to get more oxygen in. So when we start to have atelectasis, rate goes up, patient gets short of breath, they have abnormal lung sounds, and they have a cough, productive cough usually. They're struggling. Pneumonia, fever, chills, productive cough. Pneumonia is not something that's going to be present in the immediate post-op period. They don't come out of the OR and then, an hour later they have full-blown pneumonia with the fever. It takes a little while. And then pulmonary embolism we'll talk about in a minute. That's a life-threatening issue there. What kind of chest sounds, lung sounds do you have when you have infiltrate in the lungs? You may have rales, bronchi, crackles, wheezes. You may have anything. Usually they have a big fever with pneumonia. Atelectasis is going to happen earlier. Okay, but it's really, you're not going to be diagnosing it. Okay, that patient's going to be sent for a chest x-ray and going to be looking at, is it an infiltrate issue or is it atelectasis? With the infiltrate, a lot of times your sounds will be lower in the lungs because that's where it settles. Okay. So tell me what I've told you over the last 2 weeks that we do for respiratory issues post-op. What are we going to do with our patient? We're going to get them out of that bed, absolutely. So ambulation as early as possible helps to decrease pulmonary congestion, helps to improve circulation. We're going to give the patient oxygen. Incentive spirometry. Remember the little thing they have to breathe into? I showed y'all that last time, didn't I, in 102? Didn't I show you that? Okay. IS is the way when we document it, we usually put IS there. What else? Turn, cough, and deep breathe. You're going to start that immediately. That's them right there. Assessing first. Assessing rate, pattern. How are they having to struggle to breathe? They shouldn't be having to struggle. When you start getting respiratory rates less than 10, your patient has respiratory depression. You've got to intervene. And don't give their morphine. Okay? So it may just be a matter of you actually just have to stimulate your patient, rouse them up, get them to take some good deep breaths. Okay? Rapid, shallow respirations usually indicate that there is a problem with volume, like low volume, hypovolemia, cardiac problems, metabolic problems, increased metabolism, usually it speeds up, or the patient may be in pain. Rapid, shallow breathing usually indicates that your patient has shock, hypovolemia problems, cardiac issues, increased metabolism, or pain. Hypo. Because remember, that's what the body does when we start having fluid issues and low volume. We increase the rate to try to help the perfusion and get oxygen to those tissues. Okay? Heart rate will go up as well. Okay? In sinus spirometry, we're turn, coughing, and deep breathing every 2 hours. Every one on the sinus spirometry, if we can get them to do it. They don't like to do it because it just hurts for them to take a deep breath, especially if they've had abdominal or chest surgery. But they got to do it. Got to do it. Look at their chest expansion. Okay. If you have a patient who may have fluid overload and they've got those wet lung sounds, you may be giving medications to pull off some of that fluid. Remember, the elderly don't handle that fluid as well as the younger folks do. Turn, coughing, and deep breathing. Remember, we want a good, solid cough. And we want to instruct our patients to splint the area so that we don't have an open wound or a split open wound. And this is one of the ways that you can have your patient splint the incision. Simply have a pillow that they hold over the incision, and then when they are holding some pressure there, they're going to take some good deep breaths, and usually about the third or fourth, it doesn't matter how many they take, but they're going to do a good forceful cough while they're pressing on their incision. This is why we want them to practice that. We teach them at pre-op, and we have them practice it, so that when they're groggy and sleepy, that'll come back to them, that we've discussed that and they know how to do that, okay? But you have to coax them and coach them to do it post-op. They can turn on their side. It kind of helps when they're in the fetal position. It kind of helps, or have their knees drawn up. It kind of helps them to splint it as well. Not quite so much pressure on the abdominal incision when the patient is flat. When the patient is flat, it's pulling on the abdominals. So if the patient lifts their legs or turns to the side with their knees up, there's not quite so much pressure when they have to cough. Does that make sense? Okay. It did in my head, and then I said it wrong. Okay. Everything sounds great in my head. Yeah. Okay. So respiratory complications. Do you have on your things? Do you have a thing about pulmonary embolism? Okay, I'll get to it then. Okay. All right. Okay. So let's move on to cardiovascular complications. Your patient may have problems with their blood pressure, hypovolemic shock, which means they are low on volume, and as a result, they don't have enough to supply oxygen and nutrients to the cells. They can have altered cardiac rhythms, DTE or deep vein thrombosis, they can have heart failure, where maybe they've got some congestive heart failure where they've got a fluid overload. And we'll talk about that next week. They may be septic. They may develop sepsis. What is that? It's infection in the blood, and it's systemic. It's no longer localized at one area. It's all over. That's not an immediate complication, usually, unless they have done surgery on an infected part and released infection into the bloodstream. But you don't usually have sepsis immediately. Okay. Disseminated intravascular coagulation, or DIC. That's an issue where you have all sorts of problems with your clotting factors. Okay. And that is an emergency, life-threatening issue right there. Okay, they have clotting happening all over, and that's you'll get that speech probably around 202 or 203. Okay, anemia, maybe from blood loss, and then anaphylaxis, which is severe reaction from some kind of medicine or exposure to something that we've done. Okay. So what kind of cardiovascular assessment do you think we need to do on these folks? We're going to start out, of course, with just that basic stuff, doing the heart vital signs, doing vital signs, listening to the heart sounds. Your patients are probably going to be on telemetry or a cardiac monitor for a while post-op. Looking at those rhythms. Okay. And then also part of our assessment is the peripheral vascular system. How do I assess the peripheral vascular system? Distal pulses, capillary refill, what else? Color, skin temperature, and I'm comparing it from side to side, right? Okay, good. Comparing those distal pulses, making sure that we're getting good circulation to all extremities. Good. Okay. Now, one of the more common cardiovascular issues that your patient is going to have is going to be syncope. Okay. This can be just a result of the anesthesia or the surgery or their general health. Okay? What is syncope? It's dizziness, fainting, all that business, right? So your patients are groggy after surgery. They may have some fluid issues going on. So it may be because they've got some fluid deficit, decreased cardiac output. That's what CO is. They may have defects in their cerebral perfusion and postural hypotension. Patients who have had surgery, we get them up slowly. Remember I talked about the other day that when we change their positions after general anesthesia, we have to do it slowly because they can get into some hypotensive issues. This is part of that as well. Yes, sir? No, if it's fluid retention, you have too much. Deficit means you have too little, not enough. Okay. Most of the time, your true syncopal episodes happen in your older adults, but anybody can be fainty after surgery. So we always take great care when we're getting these people up. People who have been immobilized long periods of time will not do well. We have to be diligent, very careful. These are the folks that we actually raise the head of their bed, watch them for a couple minutes, then we sit them up and let them sit on the side of the bed with their feet dangling. Okay. Give them a couple of minutes to make sure that the dizziness, or that they're not dizzy. Okay, and then we're going to have them stand. Just stand at the bedside. And always be aware that they can go right down on you. So don't make them go too far that first time. Sometimes we just stand them up and let them stand for a couple of minutes and then sit them back down. You have to use your assessment skills and your judgment there. Okay? Sometimes we don't have the patient get up and walk immediately. We may get them up and sit them in a chair for a little while. I know a lot of times on the night of surgery, we'll get them up, move them to a chair, and let them have their supper, per what it is, their broth and their jello, sitting up. And then maybe right before bedtime, take a few steps. You just got to get them up and moving, but got to be careful. You can't put them in the floor either. Okay, be very careful with that. Okay. Tissue perfusion in the post-op patient, it can be altered. Okay, because of their inactivity, maybe the body positions that we've had them in, pre-op, post-op, intra-op, okay? Pressure on those areas alters their perfusion. And these are the folks that usually have the main trouble. The older adults, obese patients, and the patients who have been immobilized for a period of time. They get into problems with clots. Remember when we talked about SCIP, the Surgical Care Improvement Program? That's one of those issues that we're trying to prevent post-operatively, is the clots. So most of your hospitals now have DVT protocol and prophylaxis for patients that go to surgery. So our signs and symptoms that we may have a clot there is there's tenderness and pain in the calf or in the leg. Okay. It's usually reddened. You may see a red streak up the leg. The leg's usually warm, swollen. And you may have a positive Homan sign. That's not the be-all, end-all way to diagnose it. Okay, because you may have a positive Homan sign when you don't have a clot. Okay, but if you've got a positive Homans and you've got the rest of the stuff, you've probably got a clot there. Okay, we never massage calves. Okay, the only calf massage your patient needs is with an SCD or TED hose, not from you. Okay. Because if they do have a clot, you can cause it to tear loose, and then we do have issues. Not good. Okay. Your patients may have superficial thrombophlebitis in a superficial vein. You have the same symptoms, everything, but it's not quite. They're not quite so large as they are as when they're in those deep veins. Okay. So when we've got our patients on these anticoagulants, we continue those things at least 24 hours post-op. Because hopefully by 24 hours post-op, we've got these folks up and moving. Okay. If this patient's going to be down for a while, we're going to continue the prophylaxis. The tissue perfusion is one of those things that you've got to assess for every day. Okay, you've got to look at their legs every day. especially if you have the patient that's not ambulating. Another issue with clots is pulmonary embolism. This is when you have a clot in the lungs. This is a major, major emergency. These are your signs and symptoms, and it is usually a sudden onset. Okay? Sudden, severe chest pain, shortness of breath, very rapid heart rate and respiratory rate, blood pressure drops, and they start to have cardiac arrhythmias. You have to try to manage the symptoms. Manage the symptoms. That patient is put in the bed and they stay there. Okay? These are not the folks you get up moving them around. You don't want that clot moving any further. Okay? People die like that from pulmonary embolism. Okay? They're on bed rest. They are on oxygen. And they are on lots of anticoagulants. And you just try to give the thing time to be reabsorbed. Okay, managing that airway, cardiac respiratory status. This is bad news. Bad news. Okay? But people do survive pulmonary embolism. You catch it and start managing it. Managing it appropriately. We had a lady that had a bunionectomy. Do you know what that is? You know what a bunion is on her foot? She had that done, and she stayed overnight because she was having some pain problems. And so the next morning, she was going home, and she got up and to use the bedside commode, and she became unresponsive. And we got her back into the bed, and we coded that lady for 3 hours. We did everything but throw the cart at her. And she never responded to a thing. She just went like that, gone. And never responded. 3 hours. And that's what happened to her. She threw a big clot and after a foot surgery. It's unexpected, but it can happen. Okay, so she wasn't that elderly a lady either, but it happened. One of those things. So pulmonary embolism. A lot of times, if you're in a resuscitation and the patient's just not responding, that may be the issue right there. Okay, that they've got a pulmonary embolism. All right. So how do we handle some of our cardiac problems? Okay. One of the first things is early ambulation. Okay. Early ambulation is your really most significant nursing measure to prevent post-op complications. Because it does so many things. Okay. We're monitoring their intake and output. We're monitoring their labs. Remember, we may have some fluid issues, and when we have fluid issues, we have issues with electrolytes as well. And electrolytes affect everything. They affect muscle and, blood and all that business. Okay, so we're monitoring labs closely. We're monitoring and managing IV fluids. We have our patients do leg exercises, ambulation, positioning. Okay. TEDs and SCDs. And then, of course, we've got them, for the most part, on prophylactic measures to prevent PE and venous thrombosis. This is your heparin and your or your low molecular weight heparins, your Lovenox. That's what that is. That's one of them. There's several, but Lovenox is the main one. So what is it? What do you know about heparin? It's a blood thinner, right? What else? Anything else you know about it? It's given sub-Q in the abdomen. That is a route. You can also give it IV. Okay, you may have an IV drip of heparin. And I would pretty much bet every one of you my next paycheck, before you get out of this program, you will have one or two, at least two, questions regarding a heparin drip protocol. Not going to be in this class, but Mr. Holloway loves those. So when you get to 203, it's coming. Okay. He loves those. But you'll have patients that are on heparin drips. It's done as a piggyback. All right? And that's when you have to do monitoring of PT or PTT? PTT, right, PTT for heparin. And you're monitoring that like every 6 hours, and you're adjusting the heparin drip based on what the PTT is, okay? So you may, your patient may be on that post-operatively, but when we're talking about just the prophylaxis, that's the injections that we're giving into the abdomen, the sub-Q, all right? Lovenox is also given sub-Q, the low molecular one. And with the Lovenox and those type of heparins, you really have less major bleeding as a result of giving that. You don't have to monitor lab values like you do with heparin. It's usually absorbed a little better, and it lasts a little longer than heparin. So that's why we tend to use that. Just less complications with those things than we do with heparin. But sometimes heparin is the one we got to use. Okay. I have 5 minutes. Great. Okay. So what is one of our most important things that we can do post-op as a nurse to aid our patient's recovery? Ambulation. Yes. Okay. Ron tells me I have 5 minutes, so let's stop here before we get to the neuro. Okay, now let's talk about some neuro alterations that you may see post-op. Remember when they got to PACU? We first thing we did was look at their ABCs and their level of consciousness. We're going to continually be assessing level of consciousness throughout the post-op period, especially while they're still under effects of anesthesia. And it usually takes about 24 to 36 hours or so for anesthesia to be pretty much gone. Okay, that's when we don't let people drive themselves home. So we're assessing level of consciousness and cerebral functions for all general anesthesias and sedation patients. How in the world am I monitoring neuro? Right. You're looking at their muscular, ability to move. All right, their strength, that can they follow commands, and it needs to be simple commands. Remember, they're schnockered. They're not going to be able to do, a math problem. So we want to ask them, how oriented are they? Do you know where you are? Do you know who you are? Okay, sometimes they don't even know that. Okay, so we're measuring and looking at their, how oriented are they? Person, place, time. They may not be able to tell you the day, but they should be able to tell you what year it is. Okay, are they able to follow your simple commands? What's another main way that you check somebody's neurostatus? I hadn't heard anybody say it. Somebody said it. Their pupils. Look at their pupils. Okay. Wah, 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 wah. Yeah. Yeah. So look at their pupils. Are they're probably going to be a little pinpoint. Okay, that's okay. But do they react? And do they react equally? Okay. And then we're also assessing their sensory and their motor status. Can you wiggle your toes? Can you grip my hands? Okay, those kind of things. Simple. It can get a little more complex the less sedated they are. Okay? But remember, if your patient has had some type of orthopedic surgery or some type of neurosurgery, you're going to really be doing a more in-depth neuro assessment. Okay? I'm not checking cranial nerves on my patient who has had, an appendectomy. With somebody who's had some throat surgery or some head surgery, I might be a little more concerned with that. Okay? So the issues that you have with neuro after surgery is that you can have an emergent delirium. Your patients are just really, really confused. They may be very restless and combative. My mother actually slugged a recovery room nurse. And I'm like, thank you, Mother. I work with these people. Do you have to act out? But she did. She did. She was mortified that she did it, but she was having a lot of pain. And she had shoulder surgery to break up some scar tissue from a previous surgery. And they basically just put the patient to sleep and go, So afterwards, she's coming out of it in the emergency room, and she's restless. So the recovery room nurse, if it was going to happen to anybody, it was going to happen to this girl. She was constantly in the middle of something. So she's trying to hold her down so she doesn't hurt and get it out of the... Well, my mother just comes up with a left and just... So by the time I get back there, Sarah's holding her chin and her, and all that stuff. So I said, what is wrong with you? Well, your mother hit me. So I told Mother was mortified, but her words were, well, she ought not have been trying to hold me down. So I was trying to tell her I was hurt, and I said, well, she got the message, I think. So be careful. Sometimes they don't just wake up all nice and calm, okay? And if you had a patient who was very nervous and anxious going into surgery, when they got put to sleep, they're going to be very anxious and very scared when they come out of it. Those people tend to wake up fighting, okay? So be careful. Your children, your kids tend to do that, okay? So be careful. Be careful. And my mother. Certain, I guess you could have that if you've held their medicine, if they've been NPO for a while. Sure. So they may have the delirium. Sometimes there's just a delayed awakening, especially with your older folks. They don't come back to baseline quite quite as fast. Okay. So in that case, these are the folks that may need to be intubated a little bit longer, have an airway a little bit longer, really need to be stimulated to wake up. Okay. And basically, as far as your neuro interventions, that's what you're going to be doing. You're just going to be assessing these things here, and documenting them. So, anybody who has general and sedation, you've got to do the LOC and the mental kind of neurologic assessment. But when you're talking about those regionals, spinals, you're going to be even more concerned with the sensory and the motor aspect of their recovery. Now, patients who have surgery have issues with, or could have issues with fluid and electrolyte imbalances. Okay? This can just be a normal response to the surgery. It may be because we've kept them NPO for a while before surgery. They've been fasting. But it also can be because of the fluid that we give them and the fluid that they lose, the type and amount. Whether it's blood, IV fluids, whatever. It throws them into a state of imbalance there. Your folks who've had the pretty lengthy surgeries are going to have a lot of laboratory testing post-op. Okay. Trying to make sure that they don't have any of these issues. Some of the main ones we have to look at are fluid retention and overload, and then also fluid deficit. Fluid retention and we want them to retain the fluids that we're putting into them, okay, to maintain their blood volume, maintain their blood pressure, okay, that homeostasis that we're looking for. But sometimes if we're giving our IV fluids too rapidly, if your patient has renal disease or cardiac issues like congestive heart failure, it's the chronic kind of stuff, they tend to be more at risk for an overload. We're putting the fluids into them, but they're not getting rid of them. Or we're giving them too quickly that they're not getting rid of them fast enough. Again, it's usually your older people. Makes you kind of want to get old, don't it? Everything I've mentioned is because of old people. Fluid deficit may occur because maybe your patient was dehydrated preoperatively. Okay. Maybe they lost fluid during the surgery, or they've had a lot of post-operative vomiting. They've had a lot of diarrhea post-op. That's not a lot really, really common, but it can happen. A lot of wound drainage. They lose fluid that way too. So what happens is they have a decreased cardiac output and decreased tissue perfusion. So how in the world, and what am I doing about this? What am I monitoring? What am I assessing? I know every patient who has surgery should be on I&O monitoring postoperatively. How do we monitor somebody's hydration status? skin turgor. What else? How can you look at somebody and tell they're hydrated? Their mucous membranes are pink, moist. Okay, skin turgor is appropriate. Good. Your patients will come out of surgery with an IV. They will have IV fluids going. Usually it's an isotonic fluid like normal saline. We'll talk about that when we talk about IV therapy. But it's usually like normal saline or lactated ringers, which is it's got some electrolytes in it, and then or D5 lactated ringers, D5LR, which has got some 5% dextrose in it. So fluid balance is affected, and then when that's affected, you get into issues with their acid-base balance. All right. So acid-base is a mechanism in the body that's regulated and affected by the respiratory status, metabolic changes, and then losses of acids and bases in the body. This is when you start to get acidosis and alkalosis and all that horrendous things y'all are going to learn about in a couple of weeks. Okay? Go, thank goodness. Y'all learn it so you can take care of me. It's just something, it's complicated stuff. Thank goodness the body handles that most of the time. It's tough. Oh, you've heard it. You've talked to these people. But anyway, acid base is something, and fluid balance is all that works in conjunction, okay? So we have to monitor that. We monitor that by their hydration status, and we may be looking at arterial blood gases. That lets us know if the body is acidotic or alkalotic, and then what we need to do about that. Okay, so arterial blood gases, or ABGs, it's an arterial blood test where they're looking at oxygen levels, bicarb levels, CO2 levels. All that stuff is what regulates the acid base in the body. See? Your patients may have problems with urinary retention post-operative. Yes, ma'am. And losses of acids and bases. Do y'all remember when you had your Miss Lee probably did it. Your lecture on elimination, and they talked about diarrhea. When you have diarrhea, you lose a lot of electrolytes. It's the same thing with vomiting. So when you've actually got tubes in that are pulling out drainage, you get into problems with your acid-base balance there too. Okay. So urinary complications. Patients can get into urinary retention. We've put the patient to sleep, but the bladder gets kind of lazy as well. All right, so it takes a little while for the bladder to wake up. All right, you haven't affected really kidney function by the anesthesia, really, but the bladder gets a little lazy. That's why we want to make sure before we send the patient home, the patient has voided. We don't send people out from outpatient surgery unless they've voided. Okay. Control or take several hours to return after surgery. And it may be due to the anesthesia. It may be due to the anticholinergics that we've given them. We've dried them up. Okay. Maybe manipulation to the bladder or the ureters may affect the patient's ability to void. Maybe if it's an elderly gentleman and he's got prostate issues anyway. Okay. How do I... Yes, ma'am. Usually once they go, they can go. However, this is an elderly gentleman. He's probably got, he's got a prostate like this, and plus he's immobile. There you go. Because there's probably some reason he's not able to go. Yeah. And guys, I'm sorry. If you live long enough, you're going to have prostate trouble. Sorry. You're going to have it. You're going to have it. Somebody's hand went up over here. That was it. There's not really a specific time frame. She asked about how long they can have retention before there's an intervention. How do you know somebody's in retention? When they try to void and they can't, just means they can't void. Okay, that's a sign. But how do you know they're actually in retention? The bladder gets distended. Okay, and when the bladder gets distended, your patient hurts. That's painful. It's very painful. Okay, and because they've got to go, they're filling up the balloon and it's not going anywhere. Okay, so it is painful. When you assess the bladder, it feels like a baseball or a basketball or a watermelon, depends on how big it gets. Okay, so that's how you know they're in retention. What are we looking for as far as normal output in a patient? What do you know is normal? 30 milliliters an hour. So we're monitoring INO. Anyway, okay, the patient may have had a catheter, so when we take that catheter out, we have to instruct our patient, I need to know when you go to the bathroom, okay, because we're measuring it, and we need to know how long that is. If the patient has gone, several hours, 8 hours, and they haven't peed, you need to be looking. Okay, they may can go 12. They may can go, because you guys are going to be nurses and you're going to be out there. You're going to find you're not going to be able to pee every hour. Okay, you may not be able to pee your shift. It depends on what's going on. So the bladder will expand, and everybody's bladders are different sizes. So, but if the patient has not voided on your shift and they're a post-op patient, you need to go in there, assess them. Try to get them to pee. Maybe they're just so snockered that they don't realize they got to pee. Okay, so let's get you up. Let's get you to the bathroom and see. And sometimes just taking them in there causes them to do it. Okay, so you have to use. But if they're swollen out to here, painful, they cannot pee, then you're going to have to contact the physician, and you're probably going to have to straight cath your patient. And it may just be a straight cath, an in and out cath, and then see can they go. Give them another opportunity. Or you may have an order to just reinsert the Foley catheter. We don't keep catheters in anymore because it's such an infection risk. So you may have to reinsert it. So we're assessing the suprapubic area, checking for distension. Bladder scan, doing that kind of thing now is certainly better than what we used to have to do, which was cath them to see if they've got anything in there. Now you know before you go putting the catheter in. Let's see. You do want to report to the physician if your patient is only voiding small amounts, because folks who have women may have an overflow. The bladder will just stretch so much, and then they leak some, and just enough to relieve that pressure. The same thing with the fellas with prostate trouble. They'll pee just enough to release that pressure, okay, and they'll feel like, oh, they're great, but it just fills right back up. They only lose small amounts of urine. So if they're only losing small amounts at a time, okay, we're still trying to measure that. However, they're not completely emptying their bladder. So we need to contact the physician. If the patient is not voiding at all and they're not really distended, it may be a fluid issue, a fluid deficit problem, or a renal problem. Okay. So we've talked about respiratory, we've talked about cardiac, we've talked about neuro issues, we've talked about fluid and electrolyte issues, we've talked about urinary issues. Now let's talk about GI issues. So your patients who have surgery have all sorts of potentials, right? Lots of things that can go wrong with them. Your patients who have surgery, about 30% of them are going to have nausea and vomiting after a general anesthesia. Just kind of goes with the territory. It's very common. We try to ward it off, but sometimes we just can't. So it may be a result of the anesthesia that we give them, the type and length of surgery. And they may just have a history of that. Some patients are just always sick as 40 dogs after they have surgery. They're just sick. So in that case, hopefully we know that from their history, so that we know as they're coming out of anesthesia, let's go ahead and give them some. Good gracious, bless you. We're going to have to go ahead and give them something and have some Zofran or Phenergan on board to try to cut down some of that vomiting, okay? Sometimes just raising the head of the bed, which we've put them in semi-Fowlers, okay? Maybe we need to raise the head of the bed a little more. Will help to decrease some of that. But we really don't want them vomiting if we can help it. Right? It puts stress on abdominal wounds. It raises intracranial pressure, interocular pressure, and there's always a risk that they can aspirate. So we try to control that. Your patient may also have problems in the return of GI function. All right, so we've put the patient to sleep, we put the bladder to sleep, we also put the bowel to sleep. All right, so we expect when we're doing our assessment, we're checking GI function. How do you check GI function? You listen to bowel sounds, right? We expect those things to be sluggish or absent for the first 24 hours post-op. Especially if they've had a GI surgery. We expect that. That's not the horrendous, it's not horrendous to not have bowel sounds right after surgery. So just know that the return of peristalsis will be a little delayed, but it should start to pick back up. They'll start slow, okay? And they will be slow until we start to feed the patient or put something into the GI tract. So when you hear bowel sounds, it means that peristalsis has started again. But just because you don't hear bowel sounds does not mean that the patient does not have peristalsis going on. Okay? The best indicator that a person's bowel is working is that they're passing gas. If they've passed gas, something moved it through there. Okay? That's why you'll hear physicians go in and ask the patient if they've pooted yet or whatever. They break it down to them, Use whatever language they're going to understand, okay? Because we have to monitor that. So when we have what we call a paralytic ileus, that's where we have no movement at all. The bowel, and it's usually in the upper small intestine. No movement at all. It's like having a bowel obstruction. And the abdomen gets very distended. Mm-hmm. It just doesn't pick back up. It doesn't start back up. Now, a lot of times your patients may come to you after surgery and they already have an NG tube in place. Okay? Think back to 102 when you were talking about feeding tubes and NG tubes and all that business. What's the difference between an NG and a feeding tube? An NG tube is put in, they're all NGs really, okay? But if you've put it in a feeding tube, it's very thin, it's very flexible, and it's put in to feed the patient, right? An NG tube, in this case or in other cases, it's put in order to decompress the stomach, to keep the stomach and the GI system empty. It gives it a rest, okay? It drains fluid out of there, bile, stomach contents. Okay, so you may put in an NG tube because of an obstruction. So your patient may come out of surgery with it because of the surgery that they've had, and we'll talk about that next week. Or in the case of an obstruction, like an ileus, you may have have an order to put one in. So in the case of decompressing the stomach, then you're going to use that larger tube. Do you remember the tube that was kind of clear looking and it had the blue tag on it, the pigtail on it? How many of you know what I'm talking about? Very few. Okay. It was a clear tube, and I'm so sorry I don't have one to show you. But it was a clear tube that comes down into the stomach. It's in the esophagus, and here's the stomach, and it's down here in the stomach. Okay, this goes to suction to your canister. Okay, because in this case for decompression, we're wanting to collect what's in the stomach. Okay, so here's my fluid here. Right up here was a blue tail that came off the end of it. It's an air vent. Okay, it's blue. It's about the color of your uniforms. And there's a little valve that we stick in here to kind of cap it off. Okay, so you're going to put the tube in just like you did, when you were doing the skill in 102. But it's just a different type of tube. And you saw these tubes. Trust me. This is kind of what you use. This is what you use. But this right here is an air vent. The only thing that goes down that is air. Okay? If you put irrigation, meds, anything like that down that tube, you've screwed the tube up. You've messed the tube up. Now this sucker's going to be leaking. You don't have the equalization of the pressure, and this can actually start adhering to the stomach wall. So if you learn nothing else today, don't put nothing down this blue tube except for air. You can squirt air down it all day long. Okay. If you mess this up, you may have to take this out and put a new one in, and your patient is not going to be happy with you. Okay, so blue tube, only air, but it's a dual lumen tube. Okay, so if you're asked to put one of those down for decompression, the second you hit the area you need to be hitting, you're going to know, because it's distended. The abdomen is distended. It's hard. It's painful to palpate. The minute you hit this, that contents is coming right back at you. Okay? Your patient may have even been doing what we call projectile vomiting. It'll only stretch so far. And then they're not doing that normal vomiting. They are vomiting. Okay, across the room. I've seen them shoot it to the end of the bed, off the end of the bed. Okay, so hopefully we have intervened before we've gotten to that point. because that's not fun. You'd rather do this than clean that mess up, right? So you hook it up. This tube for decompression, you're putting it in, and you're going to connect it to intermittent low suction. Okay. If the stomach is very distended, I have seen this filled up and another one have to be put up there. Okay. So the ileus is keeping things from moving through. It is an obstruction, and you've got to put the tube in to get that empty. And then we just kind of give the stomach time, the bowel time to wake back up. This is one of those things that you're measuring as an output. Patients who have NG tubes are not fed. What's the point? Okay. We hold them NPO, but they're miserable, and a lot of times the physician will let you give them like ice chips. Okay. So where are the ice chips going? They're going to here. So if you give your patient 6 cups of ice chips on your shift, you need to know about how it's affecting your drainage here. Okay, because this should gradually decrease. Okay, it'll get the stomach empty, and then it's just a slow, a slow collection. All right, but if you're filling them full of ice chips, it's affecting your. You don't want your physician to think that they've got 300 of drainage when 250 of it is ice. Okay, so kind of keep up with how much you're giving them. Patients with NG tubes, you're pulling out electrolytes. Remember when you put the feeding tube in, or when you checked for residual, what did you do with that? You stuffed it back in, right? So that's because you're pulling out electrolytes. You're doing it here too, but you're not putting these back in, okay? So you got monitoring of electrolytes, eyes, nose, those kind of things, especially sodiums and potassium. Okay. Patients may have NG tubes they may have this tube in to feed. You know, your intermittent feeding. You can give medications down this tube. Okay. I'm just talking about the tube now. I'm not talking about with paralytic ileus. Okay. You're going to be careful putting anything down because the bowel's not working. You're not wanting to push stuff down through it. But when you're giving meds and stuff, you remember how they talked to you about giving meds down this, did they? Meds through tubes, that kind of lecture? Okay. Bring that back to the forefront of your brain. All right. You may have to do that when you get to the hospital. All right. Questions on that? Questions on GI? Let's take care of their nausea and vomiting. Let's monitor their bowel sounds to see if everything's waking back up. And if it's not waking back up, we've got to be monitoring their abdomen. Is their abdomen swelling? Is it tender? Is it getting distended? And then we need to contact the physician if we know that, because somebody's going to have to put an NG tube in. All right. Integumentary complications. Skin. Of course you're going to have issues with the skin. You've made a big old cut in it, or several cuts in it, right? Your book does talk about wound healing in chapter 27, and it talks about wound closures and primary intention, secondary intention, and yada, yada, yada. With normal healing, if you see the word approximated, that means that everything has been lined up, the skin has been lined up, and sewn together. Okay, there's no gaps and all that business. It's approximated. All Right, that's what that means. It's lined up like it should be and sewn together. When we're talking about primary intention, that just means that the wound has been closed and there are no gaps from the bottom of the wound to the top of the wound. Everything is together. I'm sorry? Uh-huh. There's no dead space in the wound. And this type of wound tends to heal quicker with a thin scar because it's sewn together and approximated well. Well, these are all wound closures. When you're talking about secondary intention, that's where it's a deeper wound and the wound has a cavity. Okay? And these wounds heal from the bottom up. They heal by filling in from the bottom. So these wounds may need to be packed. Okay. And then your tertiary intention is when you have a dirty wound. Now, Valerie, this would be along the lines of a debridement for a pressure ulcer. It's a dirty wound to start with. And so these have a high risk of infection if they're not infected already. And so these wounds are left open after the procedure, like a debridement. They go in and they scrape out the dead tissue so that all you have in the wound bed is nice, pretty pink, normal-looking tissue. Okay, but it's left open, cleaned, and then once it starts to heal, it may be closed then. I'm not so concerned that you're able to spout that back to me because you're not the one doing this. But if somebody has an open wound, you need to know what your care is with an open wound versus, a nice, closed, thin scar, that kind of thing, okay? So just know that some of them are closed, no dead space, they suck everything together, it's tied up, and you're done. You just monitor the dressing. Okay, everything should heal fine, but sometimes we leave them open to seal from the bottom up. Those heal, that takes a long time for those to heal. And then sometimes we leave them really open, okay, and clean, and then we close them once it's healing well, okay. In the normal healing process, within the first day or so, that it starts to reestablish blood supply to the wound area, to the incisional area. And it actually starts to bind together. So over the next 4 days or so, it's actually starting to lay down scar tissue, fibrin, collagen, all that stuff is starting to be laid down, and that continues for the first 2 or 3 weeks after surgery. But it takes up to 2 years before a wound and a surgical incision is healed. Okay. Completely healed. 2 years. 2 years. But in the immediate post-op period, the first couple of weeks or so, that's when we're really more concerned with infection and those kind of problems, okay? So when we have a wound, that's not what I wanted. That's not what I wanted at all. This is what I wanted. When we have an incision and a wound, we've got to assess it, of course. A lot of the times your patient, well, most of the time, if your patient's going to have a dressing post-op, they come from the operating room with the dressing already in place, like we were talking about the other day. And when you assess it, how do you monitor their drainage? You draw the circle around it and time and date and time it. Okay, you do that every time they have drainage on there. And then what did I say happens when that wound gets full, that dressing gets full? What do? We reinforce it. Put more gauze on the top and tape it. Right, good. Okay. The wounds really need to be kept clean and dry. So we try to reinforce it to wick some of that drainage away from the wound. We want to keep our wound using aseptic technique, especially if we have a drain, which I'll talk about in a minute. But the wound needs to be kept clean as long as we have staples and sutures in. So post-op, we're assessing our wound at least every 4 hours the first day or so, then maybe every 8. We expect them to have some drainage. It's not the end of the world. We expect stuff to come out of there. It needs to. Okay? But usually after a couple of days, the physician will remove that initial dressing, and then they may leave it open to air from that point on. Your drainage type from an incision should change over a period of a few days, couple days. It should start out bloody. We expect it to be. That's called sanguinous. Then it should change over to where you can tell it has some serum in it as well. It's kind of a yellowy red. Okay? Serosanguinous is that word. And then you have more serum than you do blood, and that's called serous. So know those terms and use those when you're documenting what your drainage looks like. So over the first few days, it's going to change. Your amount should decrease. We expect that. That's normal. The wound may have a crusting over it. That's normal as well. Your incision may be pink with a little bit of swelling. That's the normal body reaction to an incision. But if your incision is very warm to the touch, red, very swollen, and painful, and draining, you may see purulent drainage coming out of there, then that's an issue and the physician needs to be notified. Wound drainage should not smell. It should not have a foul odor to it. Sometimes if, what's draining out of there may not be blood. It may be fecal matter. It may not be infection. It may be bile where something has been nicked. Okay? Not often, but just know that wound drainage in a normal, healthy wound, bloody drainage, should not have a foul odor to it. Okay. Always make sure when you're monitoring your dressings that you look under your patient, especially if they have a wound or a dressing that stretches all the way from side to side or side to side. They may be oozing and it going behind them. Okay, this may be the prettiest white dressing you've ever seen, but about right here they're covered. Okay, we don't have dressings that circle our patient if there's any way we can help it, because that can be constriction. But every now and then you'll have like something going on here that goes, pretty much around your patient. So you got to flip them and look under them. A throat surgery may ooze behind their head. Okay. Always look under the bottom of the patient. Your patient will, your dressing changes should be done per your policy, your hospital policy. There's all different kinds of dressings out there. Okay. Our goal is to keep it clean and dry. If you have a very complicated dressing change, think about your patient. They may want some pain medicine before you do that. Okay? Especially if you're going to be packing it and shoving things down into a wound. Okay? They would appreciate that. Patients will probably have some type of closure over the wound, either staples or sutures. They may have just what we call steri strips, which are little pieces of tape, which I find fascinating. I keep looking for duct tape, but I didn't say that yet. Sterile duct tape. But in the case of your sutures and your staples, we're going to keep those in usually around 5 days, 3 to 5 days, depending on the surgery and how deep it is. But you may be the person to remove those. And the physician will usually order if they want them all removed or removed every third or, something like that. It really depends on your patient's risk of breaking open. Okay? So that you may at first remove every other suture or every other staple. And when you come in to do your IV stuff, I'm going to let you remove a staple and a suture so you can kind of see how that works. Okay. So just go by what they have got ordered for you. A lot of times you just remove them all and watch the incision. Now, sometimes your patients will come to you with drains in. Okay, and drains are just that. They're a drain to pull out and drain so things don't pool in there and set up abscesses and infections and big old hematomas under there. Different types of drains. It's just the physician preference. But this one here is a Penrose drain. And in your book, this is the picture that you have of these different kinds of drains. But this right here is a Penrose. It's just a latex rubber tube that's put into the wound, and it hangs out a little bit like that, and it drains by gravity. Okay? The reason it has a pin in it, a safety pin in it, is because it can work its way back down into the wound, and then you have to go digging for it. Okay? So in surgery, when the physician puts this in, they put a sterile safety pin there to keep it from going down into the wound. Okay, I was fascinated by that when I first saw that. The first time I changed it, I didn't know there was a pin there. And I took that off and I just I hit the call button with my elbow because I'm sterile. This is a sterile dressing because it's a direct in to the wound opening, so you're sterile for this one. So I hit the call button with my elbow. Can you come in here a minute? Because you have to put your nurse face on. You can't go, oh my God, there's a pin there. Okay? So when my charge nurse came in there, I said, this pin, do I leave that? She's like, oh yes, you leave that. And so when I come out, I'm like, what was that? What was that? And so that was my lesson on Penrose. So hopefully you'll know before you get in there, if you see a pin, that's why it's there. Yes. It is. But he put it down into the bed of the wound so that it would drain whatever collected there. Right. Yeah, same thing. Same thing. Absolutely. So pin roses usually have the you'll usually have like a cut 4x4 around it, and then of course this is sterile. You'll remove the dressing. You're sterile now, and you clean it, put that under there, and then a sterile dressing goes on top. These drain directly onto your dressing. Okay. So with a 4x4, you may have a 4x4 over it, and then usually I would put like a an ABD pad. You remember the ones that were like this, that open like this? You can put that over the top just to kind of protect it a little bit. You know, especially if it's draining a lot. They don't usually drain a lot, but that's the point, to get out what is there. Okay, so that's a pin rose. Some of your drains, like this one, this is a JP or a Jackson Pratt, and this one is a Hemovac. This is what's actually in the patient. See all the tubes? And then this here is what's in the patient. And it's cut to the size that you need it to be. But this here is where the drainage collects. So these are closed systems. Okay? These are, if your patient has a drain, they have a dressing over the insertion site. Okay, but these are just clean dressings over these. Okay, because they are closed. The drainage comes into here, and you as the nurse are responsible for measuring their output. Okay, now these things here, the collection things are squeezed together. Okay, and they work by suction. As they gradually expand, they pull out. They pull out the drainage. This one works by gravity. These two work by the expansion of the collection device. So this one right here, you smash it like a pancake, and when you smash it, then you seal it off here, just like a pool float. You know, it has the little thing that you stick down in there. That's how you seal these off. This one here, you just squeeze it and compress it from side to side. Okay, not down like the other one, but you squeeze that one and then you seal it off up here at the top. Okay. When you get ready to measure it, then you unhook it, you unstopper it, pour that out into a little small container, measure it, you re-squeeze it and seal it back off, and then put it back in there with the patient. Some of your patients will go home with their drains, and so post-op teaching and discharge teaching teaches them how to take care of this. How to empty it, how to measure it, record it, and then they take those numbers with them to their doctor visit. Okay, so they may keep those for a period of time. Okay. We need a break? Okay. Let's take a break. Y'all